Hi, I'm Amy.
And I'm Miranda.
And today we're going to be talking to you about how to document on psych patients. Documenting on psych patients is challenging for a lot of nurses, especially new nurses or nurses who might be floating to the psych unit who are not familiar with this kind of patient and this kind of setting. On a medical floor, typically we see things in a more objective way, but on the psych floor, most things are subjective. So we're going to talk about what that looks like, how to chart on that, and what a typical psych assessment looks like.
It's different than like documenting a wound or something because they're not going to have exact measurements.
Right. So again, we're just going to go with what a typical, well, nothing's typical.
Hypothetical.
Hypothetical patient might look like. So let's just say you just started your shift. You've assessed your first patient and now you want to chart on them. So we'll start, what I always start with, and I think the easiest way, is starting on environment and status. So first of all, were they awake? Were they asleep? I'm going to say my patient was awake. I could see them. They were in the milieu. We'll say for activity, this particular patient was, they were talking on the phone and they were maybe walking a little bit rapidly around the unit. We're not quite sure at this point what's going on, but we're going to go ahead and chart those things. And then we'll move on to mood and affect. This patient's mood, I would say, is anxious, maybe a little irritable.
And mood and affect are a little bit different because mood is like their current, how they're feeling, and affect is how they're like appearing, how they're interacting with you.
Yes, that's a good and important distinction. This patient's affect was labile, which means it was kind of up and down. So that's very typical on a psych unit. They might be doing well one moment, they're crying the next moment, they're mad the next moment. That's a pretty typical thing, so typical that we actually put it in the chart.
If it's abnormal, like if it's a bit like a more low than you'd notice or a big high than you'd notice, if that's abnormal for that patient, definitely chart that as well.
Right. And then there's a place on the charting app I use to go into more detail if I want to, but I'm going to say for our purposes for this assessment that we're just going to go with the basics. So then we're going to move on to their thought process. This patient, I would say, maybe they were a little paranoid. Maybe that's why they were walking around the unit. That would present as could be a lot of things, but I'm going to say in this case, maybe this patient was looking around corners, not trusting what people said to them. Maybe when you did your assessment, they were kind of looking around the room or asking you, why do you want to know that information?
Who do you work for?
Yeah, that would be a pretty typical presentation. And their behavior, I would say, probably restless, so that they're not really able to have like a lot of in-depth conversation. Although I will say one of the things we do on psych a lot is, psych operates from a milieu perspective, which is, again, very different from a medical floor. So
explain to me what milieu is.
I'm going to. So that means that a lot of the treatment modality happens within the milieu, which essentially means they're out of their rooms, they're in a group setting, there are structured groups that go on, but in addition to that, there's also a lot of therapeutic interactions that happen between patients or between patients and the nurse or other staff members that just occur as a consequence of being out of their rooms and socializing with other folks. So that can be a very powerful treatment modality, and also is a really telltale sign of how people are interacting with others and not just you. So if you're like, maybe it's me, but if you look how they interact with others, whether that's consistent or not. And one of the things I do a lot, and a lot of nurses do, is we'll walk with a patient is pacing around the unit and they're just a little agitated, but you're not really sure what's going on. We'll walk with them and we can do a lot of talking and kind of hashing things out, and our assessments during that time. In psych, it's very rare to be able to sit down and just go one after the other. What's your thought process? What's your mood? What's your affect? We're assessing that constantly in our minds as we're talking to and also observing that patient. So when we do our assessment, we're not done. We're still watching them, how they interact with other people in the milieu, how they're interacting with other staff members, because that tells us a lot about their internal process as well. So anyway, just kind of wanted to point that out. Then a very important thing in psych, obviously, is if they have a flag, and a flag is named differently in different hospitals, but basically, or care settings. A flag is typically something for either suicide, they've had suicidal behavior or attempt in the past, a straight behavior flag where they may have been aggressive in the past, and then also if they have any current suicidal ideation, if they're having any current homicidal ideation, Any auditory or visual hallucinations, that one's really important, especially if they're having what we call command auditory hallucinations, which means that they're having a voice inside their head that's like, kill yourself, kill yourself, kill yourself, or something similar, but that's the message that they're getting. That is an immediate safety risk, and that needs to be assessed. Oftentimes that patient will end up on one-to-one observation. And the other thing we look for is what's called a BERT. That's pretty typical across care settings for the acronym. It's Behavioral Emergency Response Team. Just means there was an incident that we couldn't manage by ourselves, or more typically happened on another floor where the psych nurses have to come and help calm down the patient or address what's going on.
It's also really important when you're doing these assessments, though, to not take these flags as, oh, they must still have suicidal ideation. Oh, Correct. They must still have homicidal ideations. Correct. Or remove any, and you want to try to remove any, what do you call it? Remove any thoughts you might have, any judgments, just to say, because their treatment could be working. The last nurse or what you did yesterday might be working today. So it's important to constantly reassess and not just assume.
Yeah. And a flag is going to typically stay on their chart for a long time. So they may have a suicide flag, but that may have been, I don't know, it depends on the facility. That may have been 2 years ago. They may have a behavior flag, but that was a couple years ago, and what you're seeing in front of you is maybe cooperative and pleasant behavior. So that's great, but just know those are things we have to look out for. We have to know that those exist, and there's something that absolutely needs to be included in your report.
Can you show me an example of what, so if we were having a suicide flag, or maybe it's suicidal ideation?
Yeah.
So it just, yeah.
So yeah, if you click on suicidal ideation, it is on the chart I use, it's going to ask you for more details about what that looks like. So obviously we'd want to go into more detail about that. Okay. And another thing we look for is safety plans. Most facilities have a safety plan that a patient has to complete before they leave. So that's something we're monitoring during admission and giving them the opportunity to complete that early rather than later if they can. Okay. So here's an example that you wanted of suicidal ideation. If somebody is having current suicidal ideation, so you're talking to them, I say something like, hey, how are you feeling? I ask my patients directly, are you having any thoughts of hurting yourself?
Yes, I am.
And if they say yes, then I have to immediately assess. I have to ask them, do they have a plan? Do they have intent? So a plan is like, yes, I'm planning on cutting my wrists with that pair of scissors over there. We should never have scissors on the site. But I'm just saying that would be
it's a freak day.
That would be something that would require immediate intervention, one-to-one with the patient, and you would not be able to leave until somebody could come over and relieve you. So
is that called one-to-one?
That would be called one-to-one observation. That's when you would initiate that. Sometimes someone's saying, yeah, I am having thoughts of hurting myself. And then if I talk to them more and I'm like, well, tell me about that. And they're like, I just don't really, I feel like I'd rather die than be here. That's more what we call passive.
Passive intense.
Passive suicidal ideation. It's not intense, just passive suicidal ideation. So that doesn't usually require somebody to sit one-to-one with them. Usually that requires a little bit more talking to and rapport building and supportive communication with that patient. But that's not an immediate threat. And we often see patients on the psych floor that would rather not wake up. I mean, that's a very typical, but we need to make sure, are you, like, they were like, well, I was going to try and cheat my meds and so I won't wake up. I mean, if they have a plan, we're looking at something different there. But a lot of times it's just, we use de-escalation techniques or therapeutic intervention. And a lot of times just those two things will address that suicidal ideation. Okay. Then another thing we're always looking at is speech patterns. So I'm going to say for this person that they were tangential. And that means they are literally all over the place. They're not making a lot of sense. If you ask them, like, how are you feeling? They're like, well, I don't know. It was, I was feeling okay. And then the birds were in the sky. And I went to the store the other day. And then it can make a little bit of sense, but it's all over the place. And then sometimes it doesn't make any sense at all. Okay, so that's somebody that's more tangential. And it's harder to assess those people because they won't really be capable all the time of answering direct questions. So that's when you have to kind of use your skills, what they call soft skills, and figure out from that what's really going on behind that. So, and we'll say that their interactions were appropriate. I mean, people can be irritated and, a little anxious or whatever, but still have interactions that are appropriate. That's common. Just because they're a little upset doesn't necessarily mean they're gonna go off the charts. So anyway, we'll say that. And then another really important thing in psych, well, it is in any,
it's activities of daily living, and how they're able to do that can really show a lot about someone's either physical or mental well-being.
Right, exactly. So in psych, if we see somebody they're not getting out of bed, they're not taking a shower, they're not changing their clothes, that is a real indication of how their mood is doing. And many times, like, we'll see people, they start to improve, then all of a sudden their grooming is better and they're showering more. And so that's a really important thing to look at. So I'm gonna say for this person, maybe they require some prompts. Like, hey, why don't you take a shower tonight? And also, important thing to know about that is it's a coping mechanism for a lot of people. So sometimes we have people that go a little overboard and they won't seriously take like hour-long showers, and we have to kind of be like, okay. So anyway, and then we also, of course, as in any floor, we're gonna assess ambulation, and we'll go with steady gait for this one. Another important thing is eating and drinking. Obviously, that is closely tied to mood.
These are all things that are very indicative of their mental status, even if they're not telling you exactly what's happening.
That's right. And that brings up a real important thing too, that, people say that a lot of people are like, oh, I don't want to do psych and I'm never going to do it. I'm just not going to work on a psych floor. I'm here to tell you that no matter what floor you end up on or what specialty, you will have psych patients. They're everywhere. So it's a skill that it can only enhance your nursing practice to learn this stuff. So anyway, I'm going to say he had some limited intake.
He's paranoid, it makes sense.
Yeah, he's paranoid. A lot of times we have folks that, we have to give them prepackaged food. They won't even eat stuff that's open. So, and we'll say they didn't go to group tonight. Okay, then we talk about medication and monitoring. So we'll say for this particular patient, they had partial compliance. So maybe they took some of their meds, but they refused others. That's pretty common. Or they'll be like, I'll take this now, but I'm not taking that other one because it's poison. So, and then I would just chart in there, paranoid. Gosh, I can't spell. Paranoid.
That's okay.
About meds. I mean, you can go into more detail, obviously, but. And then, of course, if they're on any kind of alcohol or opiate detox, we're monitoring their C1 CALS scores. So for this, I'm going to say this guy's just here for his SI and his paranoia. So he's not on that. Although he could be. Our psych patients come in, many times that's another thing. I mean, they're not just psych, they've got other medical stuff going on too. Mm-hmm. So if you're a medical floor nurse, you will use your medical skills as well on a psych floor. So for this guy, we're going to say he doesn't really have any medical issues right now, no CPAP, no glucose, and we're going to say he's voluntary. Now, if he's IDC'd, involuntary committed, that's a whole legal thing that we're not going to worry about right now, but that would basically mean that they can't leave. Mm-hmm. And we'll say vital signs were within normal limits. And then lastly, we're wrapping it up. We're always looking for, the whole saying that plans for discharge starts at admission. So that's particularly important for these folks that oftentimes, because of mental health issues, they don't have stable living options. So social work is usually heavily involved with us, trying to help them find places. So we'll say we're going to continue to explore options for discharge with him. And then I just have a standard closing that I use, but you always need to make sure that you will monitor, you include what kind of monitoring you have. The typical thing on psych units is you have to put you or a staff member has to put your eyes on somebody 4 times an hour, every 15 minutes or so. You don't want to do it by the clock because then they kind of get used to that and they can do stuff in between that's not always great. So anyway, we want to make sure we have that there. And then I would finish my chart. And this little cool app I use, you can double check. This little cool app I use, it does a narrative summary for you. So then you're done, because writing a narrative is one of the most challenging parts of psych documentation, and we'll talk about that more in another video. You have any more questions?
No, I think it's just important to emphasize the importance of removing any stereotypes you might have, especially when working in a psych unit, because that can really affect, the patient knows how you feel about them most of the time. And if you're coming in with predetermined beliefs about how different mental statuses and diseases can affect someone and how they'll treat you, that can really negatively impact both you and the patient and the hospital system as a whole. So it's just really important to try to, put those aside and focus on what's in front of you.
And remember, you have experienced nurses around you that hopefully your coworkers can be a resource for you, especially if you're new or floating to a psych floor, because it can be overwhelming and confusing, and we understand that, and we hope that these videos will help you with that.
Thank you so much.
Thank you.